Good evening, everybody, and welcome to this evening's Introduction to Depot Buprenorphine in the Treatment of Opioid-Dependent Patients webinar. My name is Samantha, and I will be your host for this evening. Before we start, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would like to introduce our presenter and our facilitator this evening. We're joined by Professor Nicholas Lintzeris. He is our presenter, and our facilitator, Dr. Hester Wilson. So Nick has worked in addiction medicine, for almost 30 years. He is currently Director of DNA Services at Southeastern Sydney Local Health District and a conjoint professor at the University of Sydney, President-elect of the Chapter Addiction Medicine at RACP. He has been involved in several trials of depot buprenorphine products and is lead author of the recent New South Wales guidelines regarding depot buprenorphine for the treatment of opioid dependence. So welcome and thank you for joining us, Nick. And also on to Hester. So Hester has a master's degree in mental health and 25 years experience working in the primary healthcare setting. Hester is also a staff specialist in addiction at Sydney's Langton Centre Drug and Alcohol Clinic and has facilitated training for doctors and other healthcare workers since 2001. So welcome and thank you for joining us, Hester.
Thank you so much.
Hand over to you now, Hester, to take us through our learning outcomes for this evening.
Thank you so much, Sammy. Appreciate it. So looking at the learning objectives, by the end of this webinar, we hope that you will understand a little bit about the clinical situations, the guidance that's available for you around injectable buprenorphine, the evidence base, the pharmacology, and the risks associated. That you'll be able to identify who of your patients might be appropriate for this injection and have clinical conversations with your patients around the pros and cons of depot buprenorphine for them. To understand that depot buprenorphine is an opioid agonist for the treatment of opioid dependency, and understand a little bit about the prescribing, how to start people, looking at dose alterations and when you might actually reduce someone to complete treatment or take them off the drug. Be able to administer subcutaneous injection of the depot buprenorphine and be aware and be able to comply with the regulatory requirements of prescribing and storing. So that there are requirements in New South Wales and they may be a little bit different to the ACT, and we'll come back to that a little later on. So yes, now must just acknowledge Professor Adrian Dunlop, who is also Director of Drug and Alcohol Services at the University of Newcastle, was involved in writing some of this presentation that Nick will be giving. Our disclosures, all of us have been involved, and my disclosures, I'm sorry, are not there, but they're very similar to Nick's. We have participated in depot buprenorphine studies and had some consultation and participation at advisory boards. Just also note that there are 2 brands of depot buprenorphine, and because they are specific and there are some differences between the medications, we will need to use the brand names Buvidal and Sublocade, and Nick will explain more about that. So Nick, would you like to take it from here?
Well, yeah, let me introduce sort of a summary of the presentation. So many of you will be familiar with buprenorphine. It's been around now for about 30 years in medicine. We've been using it for the treatment of opioid dependence for around 20 years now in Australia. Until very recently, it's only been available as a sublingual formulations, either Suboxone film, which is a product in combination with naloxone, or in the buprenorphine mono product Subutex. So they're the formulations we've had available to us up until now. Both of those medications require patients taking the medication on a daily basis, and that often means that patients have to attend either a pharmacy or a clinic, either on a daily basis or several times a week, and they may get takeaway doses on the intervening days. So the introduction this year of 2 depot subcutaneous injection formulations really is a significant sort of difference in the model of care and some of the implications for patients and for services. There are two products. There's the Buvidal products, and they come either as a weekly or monthly subcutaneous injections. And then there's the Sublocade product, and that's a monthly or 4-weekly injection only. The big difference really is the way that the depot treatment will change a lot of the inconvenience and stigma for patients. And obviously, without patients having to attend daily to pharmacies or clinics, that will reduce the cost of treatment, hopefully increase medication adherence, and reduce some of the concerns around non-medical use of buprenorphine products. For some of you that may or may not be aware that in Australia, patients themselves are actually have to pay community pharmacies for the labour associated with supervised dosing. And so most patients are paying around $40 a week, is fairly standard at most community pharmacies. And so whilst those products are on the PBS, they're Section 100, there's no dispensing for pharmacists, there's no dispensing fees for pharmacists, so the pharmacists end up charging the patients. So this treatment approach will have a significant change also for the cost of treatment for patients. So that's an overview of what we'll be looking at today. And then next slide, I think back to you, Hester, to introduce some of the cases.
Thanks, Nick. So we're going to be looking at 2 cases which we'll just flag at the beginning and then get Nick to have a run through the information and then come back to the cases at the end. I would just flag at this moment, guys, if there are any questions that come up during Nick's presentation, please put it in the chat box. If it feels like it's a good place to actually ask it at that point, I will interrupt Nick and ask him the question. Otherwise, we'll come back to them at the end. As Sammy said, we do try and answer all questions. If there are some that we can't get to, we will follow up with you afterwards. So let's come to Joe. So Joe is a 50-year-old man with a history of anxiety, depression, asthma, hypertension, and non-insulin dependent diabetes. I don't know about you guys, but this presentation, someone like Joe with these morbidities, is really common in my general practice setting. And he was also injured in a motor vehicle accident 5 years ago, and as a result has some chronic back pain. He was started on OxyContin at the pain clinic, and the dose increased over time to 150 milligrams daily, so 225 milligrams oral morphine equivalents. He found he was running out early and started seeing a number of doctors to obtain scripts. And despite this, his severe pain was actually not being very well managed, and it was interfering with his ability to work. His previous GP told him he could no longer assist him. On advice of a friend, he sought help from you. You assessed Joe and suggested that he had developed an opioid use disorder and referred him to your local drug and alcohol treatment service for further assessment. So moving on now to Joe, commenced on the sublingual buprenorphine naloxone combination through the drug and alcohol service and has continued seeing you as his GP for his general health needs. He was initially very reluctant to start treatment. You know, there's a lot of issues that come around. Geez, I have a problem with pain. I don't have a drug and alcohol problem. But the reality is, with some conversation, it became clear that the medication wasn't assisting, and that the buprenorphine naloxone combination was a really good option. So he started treatment, and he's feeling much better now. His pain has decreased, his mood and anxiety levels have improved, and he's gotten back to work. He finds a regular attendance at pharmacy a struggle at times due to work commitments, and the cost of his medications is a financial burden. So these are issues that Nick has raised. His regular medications, so he's on some asthma medications, he's on the buprenorphine naloxone combination 16 milligrams daily, plus an antihypertensive and an antidepressant. And generally his blood pressure, his asthma and his depression are pretty well managed at the moment. He's doing very well. He comes in and sees you in your general practice for his usual medical review and says he's heard about a new treatment with injections instead of sublingual buprenorphine. Okay, so keep Joe in your mind as we go through the presentation. So he's someone that is stable on treatment, but is the cost and going to pharmacy, and he's looking for something. He's interested in changing and having a chat about the changes. So we come to Mary, who is a 50-year-old woman with significant anxiety, depression, history of alcohol dependence, morbid obesity, and osteoarthritis that greatly limits her mobility. She has a lot of pain from the osteoarthritis, particularly in her knees. She started using heroin 30 years ago and has been in and out of opioid dependency treatment throughout this time. So she's injected heroin over that time. She's had long periods of abstinence from alcohol, but relapses when she feels too distressed and overwhelmed with stressful life events. She's tried methadone multiple times but finds it hard to attend daily dosing due to her limited mobility. She relapses back to heroin use when she misses dosing. Interestingly, it's easier for her to access heroin and get it delivered to her home and pay for it than it is for her to actually stay in treatment. She was admitted to hospital 3 months ago with pneumonia and was commenced on sublingual buprenorphine in hospital. On discharge, she's continued to struggle to attend daily dosing, but she says she prefers the buprenorphine to methadone and she doesn't use heroin as much. Now, one of the things about a dose of buprenorphine, particularly the larger doses, is that other opioids have little effect. And certainly for Mary, having the buprenorphine was great because it meant if she tried to inject heroin, it had very little effect, and so it helped her to not use heroin, and she was very keen not to. But she's really struggling once again with her mobility and her other health issues to get to the pharmacy or to the clinic for dosing. She's keen to stop heroin completely, but just isn't able to get to the dosing and asks if there are other options. So back to Nick.
Thank you. Thanks, Hester. I just want to, before we sort of get into the presentation, one of the key things is New South Wales Health has been very proactive and has put together a set of guidelines that describe the use of the depot buprenorphine products. They're available at that website, and as an interdisciplinary working group that put those together based on best available evidence. The guidelines come in two versions. So there's the long guidelines. They go for about 80 odd pages, and they're really oriented for sort of specialists working in the sector and address a lot of sort of minutiae around treatment. But we've also recognised that not everyone likes reading 80-page guidelines, and there is the brief guideline document that's also been developed. That's what gives a summary of the guidance in around about 10 pages, 12 pages. So we, if you want to read the full guidelines, by all means feel free, but there's also the abbreviated guidelines. Now, those guidance documents very much focusing around the depot buprenorphine products. They're really to be read in conjunction with the broader New South Wales guidelines around the treatment of opioid dependence. And those were released last year in 2018, and they're also available on those websites there. And so they will describe in greater detail things around the use of methadone, sublingual buprenorphine, and also the use of naltrexone and some of the other issues around withdrawal management and so forth. So this presentation really is an overview. And if you really want more information, I would strongly urge you to go and look at those guideline documents. For those of you who may not have a lot of experience with opioid dependence, opioid dependence is a chronic condition and it affects somewhere between 0.1% to 1% of the adult population. We say somewhere between there because it really depends on how you assess opioid dependence. Historically, we always used to think of opioid dependence was around heroin use in Australia. And that was always our focus, around illicit heroin use and injecting heroin use. Increasingly now, what we're recognising is the increasing number of patients who are prescribed opioid medications, usually in the context of pain. And with chronic opioid medication, we estimate somewhere probably in the range of 10 to 15% of patients prescribed opioids long-term develop a dependence diagnosis. So that means that now in Australia, illicit heroin use probably accounts for the minority of all the opioid dependence that we see in Australia at this time. Dependence itself across all drugs is more or less characterised by diminished control over the use of your drug. It means basically you don't control your substance use as well as you would like to, and that's often associated with a range of physical, psychological and social harms for the individual and for the people around them, families, friends, and also for the broader community. On the right there, you can see in the figure, so the main treatment pathways available for patients with dependent opioid use. So patients can either go through the withdrawal pathway. So withdrawal is that period, generally with most opioids, we're looking at a 1 week to 2 week period of patients stop their use of opioids, and there is a characteristic opioid withdrawal syndrome that occurs. Generally, most withdrawal is managed as an outpatient, but can also be managed as an inpatient. And we use a number of medications. Sublingual buprenorphine has pretty much become a standard medication now for the management of opiate withdrawal in Australia. But there are other symptomatic medications that sometimes get used, and occasionally we use methadone as well. Now, many patients after withdrawal will be looking then at moving on to drug-free treatment programs, or sort of medication-free, should I say, and that generally involves counselling programs, usually an outpatient basis, but there's also residential rehabilitation programs, and we also actually do have opioid antagonists available in Australia. So oral naltrexone is licensed for the treatment of opioid dependence. It works well for patients that are highly motivated and with very good support structures around them, but unfortunately the outcomes for most patients with naltrexone is problematic. They're poor outcomes. Naltrexone is also very difficult to use in patients with comorbid chronic pain, because if you're on naltrexone, it's an opioid blocker, and it actually really limits the ability to get any opioid analgesia on top of the naltrexone. So that's the pathway on the left. The pathway on the right is patients entering directly into opioid agonist treatment. This is a treatment modality which generally we would like to think of lasting for months to years. And again, we have to remember opioid dependence is a chronic condition, and generally we treat chronic conditions with long-term treatments. And generally the evidence tells us that the longer patients stay in opioid agonist treatment, the better their outcomes. The main medications we use in Australia are methadone and buprenorphine, sublingual buprenorphine to date. And in Australia, about 70% of patients in opioid agonist treatment use methadone, and about 30% use buprenorphine. At the end of opioid agonist treatment, patients look to come off their methadone or the buprenorphine, and there is a withdrawal program. So there's a withdrawal syndrome associated with stopping those medications as well. And after opioid agonist treatment, then likewise, we would often recommend that patients look at some form of ongoing aftercare, be that counselling, or at least follow up with GPs and primary care providers. So that's a quick snapshot of opioid dependence. Now, if we quick overview of buprenorphine, the medication. So as we said before, buprenorphine has been available for about 30 years in Australia. For 20 years, we've used buprenorphine, and we tend to use high-dose buprenorphine for the management of opioid dependence. Some of you will be familiar with low-dose buprenorphine, either in the form of sublingual tablets, so that's the Temgesic, or in the topical patches, that's the Norspan. Both of those are buprenorphine, Temgesic, and Norspan indication is for pain management. So buprenorphine is a very good analgesic, as well as we use our use for it in treating opiate dependence. Now, the reason we like buprenorphine is that it is a partial agonist at the mu receptor. So what the mu receptor is where most of the action is when we're thinking about what opioids do. So if we think about things such as analgesia, sedation, and unfortunately overdose, those things are all mediated through the mu opioid receptors. And buprenorphine is a partial agonist there. Now, a partial agonist means that you take a dose, it has an effect, but ultimately there are ceiling effects. So once you start getting a certain dose of buprenorphine, more buprenorphine will not trigger more opioid receptors. And most importantly, that's really important for reducing the risk of toxicity and overdose to buprenorphine. So unlike with methadone or other opioids such as morphine or oxycodone, if you take too much methadone or too much morphine, we'd all be familiar with the risk of overdose. With buprenorphine, that's not a big concern for us. So even at really high doses, buprenorphine on its own is usually not associated with overdose. The other sort of key aspect of the pharmacology of buprenorphine is that it has very high receptor affinity. What that means is it will preferentially bind to opiate receptors ahead of other opioids. So what that means is that it will reduce the effects or block the effects of other opiates such as morphine or heroin that may be used on top of the buprenorphine. So that's the key pharmacology. As we said there before, it's been available in Australia in sublingual tablets or film for opiate dependence for about 20 years now. And really the depot formulations is the new development that we're talking about. So next slide. So in a nutshell, what are these formulations and what's been the rationale for their development? So we're going to see in a moment, we'll walk you through the two formulations available, and they come as either weekly or monthly subcutaneous injections. And the rationale for developing these products really was around addressing the barriers to treatment and the problems of the regular attendance and daily dosing of buprenorphine. So as we said before, there's the model in Australia has meant you have to attend either a clinic or a pharmacy on a regular basis. Usually it means daily attendance when patients start treatment. And then once they stabilise in treatment and they reduce their use of other opioids, then patients start attending less often with takeaway doses. But still, that frequent attendance is a real problem for many patients in their ability to stay in treatment. And then there's the costs associated with that, and that's the labour of the supervised dosing. So you can see how a depot product, which only requires attendance to a healthcare provider once a week or once a month, will have a huge impact on the convenience for the patients, but also for service providers. The depot also means we should see fewer missed doses. That's where patients don't get their normal dose. And that's important because if a patient misses their normal dose of sublingual buprenorphine, then many of them will either get cravings or their use of other opioids, or will go into a full-blown withdrawal. And so that sort of impairs treatment outcomes because often we see other drug use occurring on occasions of missed doses. And then the other key advantage of a depot product means that we're not giving the medication to patients, which means that there's less risk of the medication being diverted to other people, either people not in treatment, and then some of the concerns we have with diverted medications where some people then go and inject their doses of buprenorphine and so forth. So overall, we're confident we should be seeing less non-medical use with the depot formulations, and that ultimately enhances the safety of the medication, but also the community perceptions around some of the problems of non-medical use and diversion. So next slide. Okay, so now let's look at the two formulations, the two products that are available. The first product is a product called Buvidal. Now, Buvidal is manufactured and distributed in Australia by a Swedish company, and this is really their first product anywhere in the world, actually, as a medication. So they're a new medication, they're a new sort of drug company, and they specialise in depot formulations. So the Buvidal product is available either as weekly or monthly doses. The product comes in a ready-for-use pre-filled syringe, and you can see there it's relatively low dose, low volume doses. So 0.16 up to 0.67 mils. So that's a pretty small dose. It's a subcutaneous injection. It's administered by a healthcare professional. That generally means doctors or nurses. And one of the key around all these products is these medications are never to be dispensed or supplied to a patient or their carer. So one of the key issues in the use of these medications is that the medication is either supplied directly to the clinic or medical practitioner from the drug company warehouse, or alternatively can be supplied to a community pharmacy, but then the pharmacist must supply the medication to the doctor or the nurse. So there's no dispensing to patients. The Buvidal is stored at room temperature, so it makes storage quite simple, and subcutaneous injections, and it can be injected in multiple sites around the body, and we'll look at that later. So the next slide. The way this medication works, these depot products work, so pre-filled syringe, once it's administered subcutaneously, once it comes into contact with water, the matrix in which the buprenorphine is embedded in slowly starts to dissolve, and slowly dissolves then over the period of the either week or month, according to whether or not you're using a weekly or a monthly formulation. On the right, you can see there some of the modelling around the kinetics, around the buprenorphine plasma concentrations. And you can see there the top right-hand figure demonstrates sort of the difference between a daily dose. You can see there's a daily increase, and then the plasma level goes down and you get the next dose. So that's what happens with your standard daily sublingual dose. And the difference there with a weekly product is that you get your peak effects over the first 24 hours, and then they slowly subside over the subsequent week. You can see what happens with the monthly product, very similar profile, where you see peak dose, peak sort of plasma concentration, Cmax in the first 24 hours, and then slow sort of taper off over the subsequent sort of 4-week period. The half-life of these products roughly coincide with the dosing duration. So with the monthly product, the half-life is around 20 to 25 days. With the weekly products, about 5 days. So it's not as though it's not as though your buprenorphine plasma levels have hit 0 at the time of the next dose. Next slide. And this is really about how we dose patients with Buvidal. Now, patients with opioid dependence can either be already on sublingual buprenorphine, and patients already on sublingual buprenorphine can very easily switch to the weekly or monthly Buvidal. And we do this according to the dose conversion table there. So it's very simple. You just align what the daily dose of sublingual buprenorphine is, and then you can see there the corresponding weekly dose or monthly dose. So patients can go directly onto a weekly or monthly dose. What we find is most patients are a little bit anxious about this idea of a depot lasting a whole month. And so most clinicians and most patients generally will start a patient on a weekly dose for the first 1 or 2 doses. Once they're comfortable, once the patient is reassured that the depot actually works for the full week, then most patients will transition over to the monthly product for long term. But it is possible to go straight to monthly. And as sort of the clinicians who have been using these products get more comfortable with the product, and as sort of the word of mouth spreads that the Buvidal monthly works amongst patients, we're seeing more and more patients going directly from the sublingual onto the monthly Buvidal. If a patient is currently using heroin or short-acting opioids such as morphine or oxycodone, generally we would generally say, look, transition over to sublingual buprenorphine for the first week and then switch over to Buvidal. But it is possible, if a patient doesn't really want to go via sublingual for a range of reasons, it is possible in Australia to go directly onto the Buvidal weekly without having to go via sublingual. So if you're commencing a patient, say, from oxycodone or from heroin or from morphine, for example, it is possible to initiate directly with a Buvidal weekly product, and we would usually say start with a 24 milligram Buvidal weekly product. Now, some patients are already on methadone. A methadone patient must transfer to sublingual buprenorphine before they can go over to the depot product. As for the frequency of injections, there's a bit of flexibility there, you can see. Whilst we say that the weekly dose should be every 7 days, patients can either come in a couple of days early or a couple of days late, 5 to 9 days, and it really has minimal impact upon the efficacy of the dose. So patients can have a bit of flexibility, and that you can see that becomes important. Either patients miss an appointment, or you may routinely be running a clinic on a Monday, for example, but Monday's a public holiday, and so you might bring the patient in a couple of days early or a day or 2 later. Likewise, we've got that flexibility with the monthly dose. We say every 4 weeks, but again, it can be every 3 to 5 weeks quite easily. There's the dosing, and next slide. So that's it about Buvidal. Let's quickly walk you through the Sublocade. Now, Sublocade is manufactured and distributed by Indivior. Indivior is the company that makes Suboxone and Subutex. So they're the sublingual buprenorphine products currently available. Now, the Sublocade is also a pre-filled syringe. There's only 2 doses available of the Sublocade, either a 100 milligram or a 300 milligram dose, and it only comes as the monthly dose. These are bigger injections, so you can see the 100 milligrams is a 0.5 mil, and that's still quite fine. The 300 milligram is a 1.5 mil dose, so it's a larger subcutaneous injection. Likewise, this product can only be administered by a healthcare provider, a doctor or nurse. This product, though, does require cold storage requirements. So it needs to be stored at 2 to 8 degrees Celsius, which means it needs to be in a refrigerator in a safe room. So cold storage Schedule 8 drugs are actually very difficult to handle. Outside of sort of hospitals and clinics, there's not a lot of facilities that actually do cold storage Schedule 8. So the drug company is actually will be organising and facilitating direct delivery to medical practitioners and to clinics, and the product can be stored at room temperature for 7 days. So the drug company will be orchestrating delivery of the products to, for example, medical practitioners if they sign up the system, and they'll deliver the product, and then it'll be able to be stored at standards or Schedule 8 storage conditions for up to 7 days. If it doesn't get used within the 7 days, then it has to be discarded. You can't put it back in the fridge. And another point of difference with the Sublocade is that this is an abdominal site only. So we don't put it into the thigh or into the buttocks or the upper arm as we do with the Buvidal. The next slide. The dosing with the Sublocade is pretty simple. Patients to be eligible for Sublocade must be on sublingual doses for at least 7 days of buprenorphine. So you can't initiate a patient from heroin or from morphine directly onto Sublocade, and patients must be on at least 8 milligrams of sublingual buprenorphine. So if you have patients on low dose buprenorphine, say 2 milligrams or 4 milligrams, then Sublocade's probably not the preferred medication, and the Buvidal probably is better suited to low dose patients. The dosing model here is slightly different to the approach with the Buvidal. With the Buvidal, we match the Buvidal dose to the sublingual dose. With the Sublocade, it's a little bit different. What we do is we start all patients on 300 milligrams for the first 2 months, and that gets the plasma levels up, and thereafter patients can be maintained either on 100 or 300 milligram doses according to the response. Likewise, there's a little bit of flexibility here with the dose, and doses can be administered about every 4 weeks, but you can see that you can go up to 2 days early, 26 days, and up to 6 weeks after the last injection. So 26 to 42 days is pretty standard for the Sublocade product. The evidence, the studies that have been done looking at the evidence for these products are very, very similar. So similar studies have been done both for the Buvidal and Sublocade, and we can sort of cluster the evidence around 3 domains. The first is the issue of blockade. Now, when we use methadone or buprenorphine to treat opioid dependence, one of the effects that we want from the medication is we want it to reduce the effects of additional opioid use. So both methadone and sublingual buprenorphine achieve that at high doses, and this is important because what it does is it reduces continued opioid use on top of your methadone or on top of your buprenorphine, because patients will go and inject their heroin or use OxyContin on top, and they'll just find that it just doesn't work that well. And so a lot of the positive rewards of continued or persistent opioid use are not there with this blockade effect. So studies have been done both for Buvidal and Sublocade, and they have demonstrated in sort of laboratory studies that they do reduce the effects of additional on top use. So in some cases, it's either full blockade, so there's no effects, or at least diminished effects. So that's the blockade, and we can give both products a big tick when it comes to will it cause blockade effects. The next is the issue of efficacy. This has been looked at in 2 big randomized controlled trials. For Buvidal, it was an active comparator, so the comparison was Buvidal versus sublingual buprenorphine. That paper was published in JAMA, and the reference is there. And basically, that study demonstrated that Buvidal was as good as sublingual buprenorphine. It was a non-inferiority study, so it was as good as buprenorphine in both retention and reducing on top opioid use. And the SUBLOCADE study was it was a US study. The US-like studies where the comparator is placebo, so it was comparing SUBLOCADE to placebo, and the SUBLOCADE was demonstrated to be far more effective than placebo in the outcomes of treatment retention and reduced opioid use. We've also looked at effectiveness. Now, effectiveness is not under sort of double-blind randomized controlled conditions, but effectiveness studies actually look at open label studies. That means doctors and patients know what they're getting, that it's not blinded. And we allow the doctors and patients to use the medication under natural conditions. Now, we in Australia participated in a big study looking at that. That was long-term treatment. And what we found in that study, so that was the first time we started using the Buvidal product in Australia. We did that at a number of clinics in New South Wales. And what we showed, and South Australia as well. And what we showed that the medication, the Buvidal, was easy to use, side effect profile was good. We'll look at that in a moment. Had really good treatment retention. And, you know, the clinicians and the patients who were using it, we actually quite liked the medication. So we thought this is a good medication and we can't wait for it to have it licensed. And that's what's happened. So that's an overview of the evidence. And we've got references in the slide deck later. And anyone wants to go and chase up those references, they're available there as well. In terms of administering the products, these are very simple medications to administer. They are subcutaneous injections. If you go a little bit too deep and you go into a muscular, that seems to be fine and hasn't been any problems with it. And really what I just want to reiterate the issue around this medication should never end up in the hands of the patient. And this is a TGA requirement around these medications. The concerns are that if it got into the hands of a patient and someone was to inadvertently, or maybe not inadvertently, if they were to go and inject it intravenously, then that could cause some real problems in terms of the depot then sort of forming either on tricuspid valves or hitting pulmonary vascular beds, and we really don't want those things happening. So that's why the TGA has registered both products to only be supplied to a healthcare provider who must administer the medication. Now, there are some useful videos that both companies have provided. The Cameras product is available online. So if you go to their website and if you Google search Buvidal, you'll find the website. And if you need an APRA login number, and once you've put in your APRA login, because they're not doing direct sort of, you know, marketing to patients, so you will then see all the materials available from the Buvidal product. The Indivior product, I should have said, SUBLOCADE product actually, it's licensed, but it doesn't have a PBS listing yet, and so the company has not made it available for use in the community yet. There is one study currently underway with the SUBLOCADE product, and there's a number of sites in New South Wales that are currently recruiting. So North Sydney, St Vincent's and Newcastle are the 3 sites in New South Wales. So you may be coming across patients on SUBLOCADE, but it's not really available outside of research context at the moment. So next slide. Adverse events. So most of the adverse events that we need to concern ourselves really with these products are the local injection site issues. And generally with both products, we see about 10 to 15% of patients reporting transient and usually mild adverse events, a bit of pain, a little bit of swelling, a bit of redness. This almost always subsides. You know, the pain usually subsides in a matter of hours, the swelling and redness within 1 to 2 days. Very rarely are the local injection site problems longer term problems. The SUBLOCADE is associated with a bit of a lump. That's not uncommon when using SUBLOCADE, so a little lump in the abdomen, and that generally settles down over the first 1 to 2 weeks. Both these products actually, they're not like implants that patients could sort of surgically try to cut out themselves. There's nothing there to really cut out. So we haven't really seen those kinds of problems occurring of patients, trying to cut out the depot, so to speak. There's also the broader range of side effects that one can get to sort of buprenorphine. And the most common side effects we see with buprenorphine, most of them are opioid related, so nausea, constipation, sedation. All opioids can cause this sort of paradoxical poor sleep, and it seems to be more of a problem with buprenorphine than a lot of other opioids. And buprenorphine also seems to have this particular adverse event of headache, which tends to be commonly reported. Okay, so next slide. And finally, I guess some of the key issues around what do our patients think of this. So in the study that I was referring to before, which was the open label study, that's really the first study where patients receiving buprenorphine have actually been asked to tell us about their ratings of sort of satisfaction with the medication. And you can see there that there was quite high levels of satisfaction with the depot product compared to the sublingual. Still need to highlight though, there still was around 10% of patients who actually said, no, I prefer the sublingual to the depot. So whilst we can expect the majority of patients to actually be happy on the depot products, let's not forget there are some patients that still will prefer the sublingual. And so that really raises, highlights that whenever we're talking to our patients around these products, those 3 points there are really important. So this really needs to be informed decision-making with our patients, and we need informed consent. So the decision to try the depot really should be so the patient needs to be involved in that decision. In order for them to understand what's involved, it means we have to give clear and easy to understand information to our patients, and patients should also always have the opportunity that if it's not working, there's always the option they can go back to the sublingual. I think that should be it. Okay, and then again, the summary of the advantages and disadvantages. We've spoken at length about the advantages, so I won't go over those again. But just to highlight why some patients may not like the depot. So we may find that some patients who currently, for example, get a lot of takeaway doses, that being on the depot means that they will reduce the autonomy, they will lose the autonomy over how they use their medication. Some patients, the daily attendance for dosing or the frequent attendance, several times a week means that some clinician is actually looking at them and reviewing them on a regular basis. And there's an element of you do lose that sort of daily contact with the patient with the depot products. Now, of course, if you're concerned about patients going, missing for a month or so, you've always got the weekly products, and if you've got patients that you're concerned about, then the weekly is a nice kind of option there. And we mentioned that some patients will get side effects to the depot products. And key issue there, we should always remember, treating patients with opioid dependence is never just about the medication. Patients, we also need to be encouraging our patients to participate in counselling and other psychosocial interventions. Patients need to be reviewed regularly. And as Hester highlighted, most patients with opioid use disorders also have a range of other medical, mental health and social comorbidities. And so effective treatment means we also have to attend to those comorbidities. Now, what we've generally found with the depot treatment, that when patients are turning up for their depot injection, that's when you get to do the case management, the clinical reviews, and that's when you can get to follow up, the mental health and all those other issues. Next slide. Safety issues, we've mentioned adverse events, driving. Look, probably not as much of a concern with buprenorphine as we have with methadone. The key concerns with the depot is that patients may experience some sedation in the first couple of days after each injection. And so they should be warned that over the first few doses, just be prepared that the medication may be a little bit sedating and not to drive if they feel that the medication is affecting their ability to drive if it's sedating them. Drug-drug interactions is the same as other buprenorphine products. Most of the concerns are overdose related. and that's about the risks of mixing other sedative drugs, alcohol and benzos on top of any opioid. Pregnancy, the medications, Buvidal, the TGA listing is that it is not recommended in pregnancy, but that's not the experience of buprenorphine more broadly. And in Europe and in the US, both products are actually have been licensed as suitable for use in pregnancy. And so generally what we consider is think about a risk-benefit assessment for any patient. If any concerns around the depot, you can always put the patient back to sublingual. There's always going to be concerns around pain management for patients on depot. Generally what we find is it's not really different to managing any other patient on sublingual buprenorphine. And the management strategies for patients with pain on buprenorphine, most of them are non-pharmacological. So there's all the standard non-medication approaches. When it comes to medication, your options are all the non-opioid options, so non-steroidals and those kinds of medications, paracetamol. If you have to use opioids, you can achieve opioid analgesia either by giving higher opioid doses than usual, so you can just increase the dose of oxycodone or morphine, it will work. Or alternatively, you can use the superagonists, such as fentanyl, those kinds of medications. They're usually required though only really in a severe acute pain, and that's really done by anaesthetists in hospital settings.
Nick, can I just interrupt? There was a question from one of our GPs around, does this buprenorphine injection work as well as other opioids if you've got someone that has chronic non-malignant pain?
Yeah, thank you. So most of the research has been done. All the research around opioid dependence has been on looking at opioid populations and outcomes. Now, clinically, many of us have been using this medication in patients with concomitant pain and opioid dependence. And I think to date, all the clinicians have been using it in those kinds of patients, the opioid dependent plus chronic pain patient. We've all been pleasantly surprised about just how well this medication works. And many of us actually, we're actually feeling quite confident that the depot actually probably provides better analgesic cover than some of the sublingual doses where we're having to often split the dose and a whole range of other issues. I just want to give you all a heads up that the Buvidal product, actually there are trials underway in the US where they're looking at the Buvidal product purely as a analgesic medication, so purely for a pain indication. So the Buvidal, we expect one day, should the trials prove to be effective, and should the company, I'm sorry guys, there's an ambulance going by, should the company pursue registration, then that one day it may well be that we actually have Buvidal both as indicated both for pain management and opioid dependence, but that is in the future. So buprenorphine is a very useful analgesic medication. And so far, we're confident about its use for chronic pain as well. I might just quickly add, though, when we use Suboxone, for example, sublingual high-dose buprenorphine in patients who have chronic pain, we really only, its indication is for patients who have opioid dependence. So you can have, of course, both pain and dependence. So at this point in time, using Buvidal or Sublocade, or Buvidal is the one that is currently available on the market, Buvidal, if you want to use it for a patient with pain, you need to be confident the patient also has opioid dependence. So if they don't have opioid dependence, then really it's not the current indication for the depot products.
So Nick, I've got another question here, which is one of our GPs saying, look, at what they've understood is that the higher dose buprenorphine, sublingual buprenorphine of 32 milligrams, what they've found in Adelaide was that moving it to the injectables, actually the patient wasn't being held by that dose. They were having withdrawal symptoms. Have you noticed that at all in Sydney?
So this is one of the, so these are the studies that we were looking at in terms of those issues around the doses. So this is also one of the things to be aware that many patients will come back after their first injection several days later and say, I'm in withdrawal, it's not holding me, it's not holding me. When you actually sit down and you go through it, what you find is actually they're not so much in opiate withdrawal, but there's a lot of anxiety associated with their presentation. And a lot of it is, I haven't had a medication today or yesterday or the day before that, and I'm used to taking a medication every day. So there's a lot of this anxiety associated, and that almost always settles down after a couple of doses as the patients actually then sort of realize, actually, no, the medication is holding me and I shouldn't get too anxious about it. So a lot of the things that get called withdrawal in the first dose or two actually turn out to not be withdrawal. As for the higher doses, look, there's always the opportunity you can do top-ups with the Buvidal. So the highest dose we have available, licensed in Australia, is 128 milligram dose, but you can do top-up doses on top of that if it's not holding a patient. If it turned out, though, that a patient genuinely was not being held on the 32 milligrams of Buvidal, from high-dose sublingual, if they've moved over to the Buvidal and they're not being held on the high dose, even with top-up injections, then should that happen, then that's the kind of patient where you may consider moving them over to the Sublocade 300 milligram. How often has this happened? Yet to be experienced, really, in most of the trials. We also need to put in context, the Adelaide clinicians, I think, actually only ever recruited a sum total of 6 patients on Buvidal. So I think it's fair to say that there's limited experience of Buvidal in Adelaide. They've had much more experience with the Sublocade product.
So Nick, just coming out of that was a question about what you were saying before, that Sublocade and Buvidal are not equivalent. But what if you want to transfer from one to the other? What are the issues there?
Yeah, so generally the products say if you're on Buvidal, you should stay on Buvidal. If you're on Sublocade, you should stay on Sublocade. And the products, clearly drug companies, when they do their research and they list the products, they don't really want patients swapping to the competitor drugs. So if you look at the product label, it says nothing about going from Buvidal to Sublocade or Sublocade to Buvidal. Clinically, however, there may be circumstances where a patient is treated with one medication and for one reason or another, you want them to move to the other medication. So it could well be, for example, that say they're on Sublocade in Adelaide, they do a temporary transfer into your service, but you've only got Buvidal available. Can you treat them with Buvidal? And the answer is yes, you can. There is guidance available in the New South Wales guidelines. We have written a section in there that describes the process there. And generally what we say, if you're on really high dose Buvidal, then you go over to the 300. If you're on lower doses of Buvidal, you would go to the 100 milligram and vice versa. So we provide advice in the guidelines there on how you can do those transitions.
Okay, Nick, sorry, I am aware of the time. There's lots of great questions which we're not going to be able to get to because we've only got a limited time left. So can I ask you to move on? Sorry for my interruptions.
Yeah, very quickly. Yeah, no, they're good questions. Very quickly, coming off depot, look, eventually when patients come off buprenorphine, we expect there to be some withdrawal. To date, it hasn't been well characterized, so we don't know how severe it's going to be. The few cases that we've been following up, generally, what most patients have been describing is very mild withdrawal occurring weeks to months after the last dose. But these are not formal studies. It's, we're talking about a handful of cases, but it's looking optimistic about what the withdrawal profile might be. So I might just move on, and I think we're going to move on now to some of the regulatory requirements. Now, this is important to understand. In New South Wales, so when the TGA licensed these drugs and register them, they actually put sort of caveats around their registrations. So both products are restricted to specialist rehabilitation settings, this is the way the TGA termed it, for the first 6 months of their registration. So Buvidal, we expect from around January 2020 onwards, will be available outside of specialist clinic settings. So if you work in a public clinic or a private clinic in New South Wales, you can access these medications, but if you're a GP, you actually can't start prescribing these medications until early next year. It'll be January, February next year. To prescribe, if you've already got a permit for the patient for buprenorphine, you don't need a new permit. You just contact the PRU and let them know I'm transferring the patient from sublingual to the depot. If you're going to commence a patient, though, you need to get your authority for buprenorphine. As for writing prescriptions, it's all the standards, Schedule 8 requirements, you know, words, letters, numbers, all those kinds of issues.
So Nick, just a flagging in terms of the New South Wales regulations for us GPs working in New South Wales, it is, you can do an OTAC course, which will allow you to prescribe for up to 200 people in the community setting, or you can now in New South Wales prescribe for up to 30 people. That's 20 people on Suboxone and 10 people who are stable on methadone. Now, you were saying before, Nick, that at the moment GPs cannot prescribe until we hope the changes happen early next year. And will that mean at that time that a GP who is not approved, does not have, is not an approved prescriber, can actually commence people on buprenorphine and on the and then transfer them or start them on the injectable if they're in that group of GPs that do a little bit of this work but don't actually have unauthorized prescribers?
So the current wording that we've been following is that if a doctor is eligible to get a permit for buprenorphine sublingual, then they will also be eligible to get a permit for depot. So whilst we say you can prescribe sublingual buprenorphine without having done the full OTAC course, they still have a number of requirements of you. So if any of you ever try to do this, prescribe without having done the accreditation course, the health department will just give you a call, make sure you're not, you know, you haven't had your Schedule 8 prescribing things, you know, restricted, and just make sure that, you know, there's no sort of warning signs from their end. So they've got a checklist that they follow. So if you are eligible to prescribe sublingual buprenorphine, then the current logic that New South Wales Health are working upon is that they will do the similar kinds of checks and allow you to do a depot. Having said that,
so that will be from early next year.
Yeah. Having said that, New South Wales Health reserve the right to change their minds. So in the new year, once it comes off the restrictions, I think they will pay closer attention to this and they may fiddle with that. But that's the current model that we're working on.
Fantastic. Just moving on to this next slide. So I just want to flag for any of our GPs who are working in the ACT, we currently have Megan Arnold from ACT Health who's online. So if there are any specific questions from an ACT point of view, if you just send a question and she will answer that in the chat back to you. So what we have on the screen now is the ACT Health authorities' advice around a depot. They're considering requests for primary care services as to whether they'd be considered or approved as a specialist drug rehabilitation clinic. So people that are practicing in approved services or clinics can apply. And at the moment, there are no additional restrictions on supply of depot buprenorphine products. No additional training is required in the ACT over what the sponsor has provided. But any particular issues that you want to raise, if you flag that, say you're a GP from the ACT, and ask Megan in the chat, she can respond directly to you. Thanks, Nick. Moving on. We've got 2 minutes left.
Back to the cases now.
Yeah, so just coming back to Joe. So Joe is the guy that we're seeing in our general practice. There's lots of other health issues. He's really stable on his sublingual buprenorphine, and he's interested in finding out whether the injectable would be an option. Nick, what would you say? If you got a call from a GP saying, look, this is a situation, is it appropriate? What would you say to the GP?
Yeah, look, Joe's look, there's all these issues going on for Joe, and overall he's doing well in treatment, but is struggling with, you know, the payment and having to turn up for dosing. So the depot, I think, would be a good medication to trial. Obviously, you would have the discussion and say, look, here are the potential advantages for using it. And I would probably be looking at transitioning Joe from the sublingual 16 milligrams a day, I believe he was on. I think that's on the next slide.
Yep.
And I would be recommending a weekly, Buvidal weekly to begin with. And if you go back into your conversion tables from memory, don't quote me on this, I think it's the 24 milligram Buvidal weekly. Yep. And I would give that a try. Review him a week later. Tell the patient, tell Joe, look, if it's not holding you, if you're anxious, if you're not worried, give me a call. Let's talk about things. You can always get top-ups if it's not holding you, but generally most patients are fine. They come back, review a week later. At that point in time, if the dose is about right, so again, if the good pain control, no side effects, no other concerns, stay on the same dose, and you could even offer whether or not the patient wants to move over to the monthly dose, and then you just use the same conversion table, and the 24 weekly then turns into 96 monthly.
96. Yep, beautiful. So I mean, certainly for you guys as GPs, if you do have a Joe where you're looking at that at the moment, you can't do the transition yourself, but have a talk to your local drug and alcohol clinic and see how they can assist you, or plan to have that conversation again in the new year. Moving on to Mary. So Mary is a different patient. She may well be a patient that you're seeing in your general practice for other health needs, but she's a patient that's been seen in the specialist setting. She's a long-term heroin user, finds it difficult to get in for daily dosing. She has significant respiratory issues, so moving to buprenorphine is a very good idea generally for her. But she's once again struggling to come in for daily dosing. She's complex, she's still using heroin, there's lots of other health issues going on for her. Nick, is she an appropriate one to trial on the injectable buprenorphine?
Look, we've had really good success with these kinds of patients with the depot, and a lot of it has to do with when patients miss their normal dose, the drug doesn't work. So if you're missing doses, and Mary's got problems with mobility and actually finds it easier, as you said, to sometimes miss a dose and just use heroin instead. So for Mary, I think a trial of the depot is worth considering. No guarantee it's going to work, but as with all these medications, give it a try. If it works, good. If not, you can always go back to the sublingual.
Terrific. We'll move on to the last case study. So Julie has been stable in opioid dependency treatment for some years. She works full time. She's got kids. Her 2 younger kids live at home with her and a partner. She's not used any psychoactive substances for years. Her general mental health is good. Hepatitis C has been treated. She's hepatitis C negative. She commenced on the injectable buprenorphine as part of a clinical trial and now continues on monthly injections. She's not using any other medications. She wants to decrease and cease treatment. Nick, how would you talk to Julie about how she could do that with the injectable buprenorphine, or would she need to change her medication?
So the key thing about talking to patients about coming off, treatment is being ready and being prepared. And basically, you want patients to have a good prognosis, because what we know what happens is when patients come off their methadone or their buprenorphine, they're always at risk of relapse, and both to heroin use or to other substance use. And one of the real concerns also with patients coming off methadone or buprenorphine is the risk of overdose. So mortality rates go up again when patients come off their methadone and buprenorphine. So the big discussion there is about the challenges about coming off buprenorphine altogether. We think the depot is going to be a good medication because if you think about it, what we like to do when we bring patients off methadone or buprenorphine, we like to slowly bring the dose down gradually over time. And that generally requires patients, to change the dose regularly over time. If you think about it with the depot, the drug's doing that itself. So it's automatically slowly reducing the plasma concentration over time. So it's all sort of like automatically doing its own dose reduction. The other advantage that we think with the depot buprenorphine, with the depot products, is that we've broken that cycle of the patient taking a medication every day. So they're no longer in that behavioural, I've got to take a pill or else I'm going to feel unwell. And the medication is slowly tapering off. So pharmacologically, we think this is a good medication option. But what we really would be emphasising with all withdrawal, you've got a plan. The plan should be, good assessment, good prognosis. Make sure you're reviewing the patient regularly. look at what psychosocial supports, counselling may be worth doing. Review the patient regularly, and if things aren't working, be prepared to step in and pause the reductions, or pause the and stabilise the patient again.
Fantastic. So look, I am aware of the times. We move on from that slide.
Yep, and look, they're the resources.
So there were some questions about where to go for further resources. Fantastic. Once again, these will be available to you after the webinar. Next slide. Okay, some references. Once again, they'll be available. And back to the learning outcomes. So we will be finishing up the webinar now. Look, you guys have asked lots of fantastic questions and there hasn't been time to answer them all. What we will do is I'll ask Sammy to send them out to Nick and I. We'll answer them in email form, and then Sammy can send them on out to you. If there's any additional questions that you want to ask afterwards, of course, that's great as well. So I'm hoping that this has been a useful conversation. And Nick, thank you for letting us, giving us some information. You've had a lot of experience with the injectables, probably more than anybody else in Australia. So you're the go-to person for this. And really, look, this is a really fantastic drug that assists people to get on with their lives. And we hope in the near future that it'll be something that us as GPs can actually prescribe for our patients. I would also say to anybody, to get to know your local drug and alcohol clinics where you can actually access help and support to assist your patients at any time as well. So thank you to Sammy and the RSVGP for running the session. Thank you to all our people who attended. It's brilliant. We had 150 people attending. And Nick, thank you so much for your time. We really appreciate it.
Pleasure. Thank you.